A 57-year-old male lorry driver presented to his local emergency department with a 20-minute episode of diaphoresis and chest pain. The chest pain was central, radiating to the left arm and crushing in nature. The pain settled promptly following 300 milligrams aspirin orally and 800 micrograms glyceryl trinitrate spray sublingually administered by paramedics in the community. He smoked 20 cigarettes daily, 38 pack years, but was not aware of any other cardiovascular risk factors. On examination, he appeared comfortable and was able to complete sentences fully. There were no heart murmurs present on cardiac auscultation. Blood pressure was 180 by 105 mmHg, heart rate was 83 beats per minute and regular, oxygen saturation was 97%. What is the most likely diagnosis? A. Acute coronary syndrome. B. Aortic dissection. C. Esophageal rupture. D. Peptic ulceration. E. Pneumothorax. Answer is A. Acute coronary syndrome. Although the presentation could be attributable to any of the above differential diagnoses, the most likely etiology given the clinical picture and risk factors is one of cardiac ischemia. Risk factors include gender, smoking status, and age, making the diagnosis of acute coronary syndrome the most likely one. ECG on admission. 30 minutes later, the patient's chest pain returned with greater intensity whilst waiting in the emergency department. Now, he described the pain as though an elephant is sitting on his chest. The nurse has already done an ECG by the time you were called to see him. What would be the optimal management for this patient? A. Administer intravenous morphine. B. Increase GTN dose. C. Observe as no new significant changes. D. Proceed to coronary angiography. E. Thrombolyze with alteplase. D. Proceed to coronary angiography. The ECG shows ST elevation in leads V2, V6 and confirms an anterolateral STEMI, which suggests a completely occluded LAD. This ECG fulfills the criteria to initiate reperfusion therapy, which traditionally require one of the three to be present, according to guidance. If the patient can undergo coronary angiography within 120 minutes from the onset of chest pain, then this represents the optimal management. If it is not possible to undergo coronary angiography and potentially percutaneous intervention within 2 hours, then thrombolysis is considered an acceptable alternative. Greater than or equal to 1 mm of ST change in at least 2 contiguous limb leads, second and third AVF, 1 AVL. Greater than or equal to 2 mm of ST change in at least 2 contiguous chest leads, V1, V6. New left bundle branch block. GTN and morphine administration can be considered in parallel, but they do not have a prognostic benefit. He was taken to the catheterization lab where the left anterior descending coronary artery, LAD, was shown to be completely occluded. Following successful percutaneous intervention and one drug-eluting stent implantation in the LAD, normal flow is restored. Thrombosis in myocardial infarction, TIMI is equal to 3. 72 hours later, he is ready to be discharged home. The patient is keen to return to work and asks when he could do so. When would you advise him that he could return to work? A. 1 week later. B. 3 weeks later. C. 6 weeks later. D. Not before repeat angiography. E. Not before an exercise test. Answer is E. Not before an exercise test. This patient is a lorry driver and therefore has a professional heavy vehicle driving license. The regulation for driving initiation in a lorry driver following a STEMI may be different in various countries, and therefore the local regulations should be followed. In the UK, a lorry driver holds a Category 2 driving license. He should therefore refrain from driving a lorry for at least 6 weeks and can only return to driving if he completes successfully an exercise evaluation. An exercise evaluation is performed on a bicycle or treadmill. Drivers should be able to complete 3 stages of the standard Bruce Protocol 17 or equivalent, e.g. myocardial perfusion scan, safely, having refrained from taking antianginal medication for 48 hours and should remain free from signs of cardiovascular dysfunction during the test, notably angina pectoris, syncope, hypotension, sustained ventricular tachycardia, and or electrocardiographic ST segment shift, which is considered as being indicative of myocardial ischemia, usually greater than 2 mm horizontal or downsloping during exercise or the recovery period. For a standard car driving license, Category 1, driving can resume 1 week after successful intervention providing that no other revascularization is planned within 4 weeks. Left ventricular ejection fraction is at least 40% prior to hospital discharge and there is no other disqualifying condition. Therefore, if this patient was in the UK, he could restart driving a normal car 1 week later assuming an echocardiogram confirmed an EF greater than 40%. However, he could only continue lorry driving once he has passed the required tests.